Hello, overcomers, and welcome to this episode of Connect Ovar Coffee. I am Runsi, the founder of Overcome, and today we are chatting with the one and only Dr. Tyler Hillman. So, Dr. Hillman is associate professor at the University of California, San Diego, and he's a global expert in rare gynecologic cancers, particularly ovarian granulosa cell tumors. And his research aims to discover new treatments for these diseases by understanding their molecular basis and translating these findings into clinical applications. Passionate about translating lab findings into clinical trials and treatments for rare gynecologic cancers, Dr. Hillman takes a patient centered approach, considering himself as part of the patient's team. And we love that so much. So, today, for the next 45 minutes to an hour, we are taking a deep dive into rare gynecologic cancers, again, focusing on granulosa cell tumors and other recent hot topics in this field. And this is a structured program, so we'll take your questions and convey them to our episode guest and post all answers as and when we receive back on our YouTube comment section. So if you have any questions, please put them in the comment sections. So with that, warm and huge welcome to you, Dr. Hillman, to this episode of Connect Over Coffee. Thank you for sharing your time and your knowledge with us.
And thank you, Runsi, and all the overcomers out there. I really, really appreciate it. It's a real privilege.
Thank you. So many questions, because this is a topic of great interest in our community. But before we take a deeper dive, I know that you're considered a global expert and specialist in rare gynecologic cancers. So can you tell us, as a way of introduction, what rare gynecologic cancers even mean?
Yeah, so there's a couple ways to think about that. From a research perspective, the National Cancer Institute organizations in Europe, they have numbers. And so usually those are what are called an incidence rate out of 100,000. So typically less than 6 out of 100,000 women are affected by a disease. It would be considered rare by the National Cancer Institute. And, those research programs would be considered focused on rare cancers. So for something like, epithelial or high-grade serous ovarian cancer, which is what we would consider the most common type, it's probably above that, depending on the population and the geographic location. It's probably more like 10 to 15 per 100,000. In contrast, granulosa cell tumors, which is one of my main areas of focus, would be about 0.5 to 1 per 100,000. So close to 10 times less common than the more common types of ovarian cancer, which already, compared to some diseases, would be considered rare cancers. So quite rare, but yeah.
Makes sense. Thank you. So it seems your lab is doing some great work in identifying therapeutic vulnerabilities and developing new clinical trials in rare ovarian cancers. Can you talk to us more about that?
Yes, so the lab has been very busy, really starting from scratch with this disease in a lot of ways. So, granulosa cell tumors present some really unique challenges in how they differ. We can get into that later, perhaps, but we've taken the approach that we really need new ways of studying them in the lab. So we've developed, models based on patient samples that have been generously donated by overcomers and others who have undergone surgery with me. We've taken that tumor tissue and we've grown it in what are called tumoroids or organoids that then we test different drug combinations sort of on a patient-specific basis. And we've also kind of expanded that into larger drug screens to try to identify what drugs might be out there, might be used for other diseases, maybe not even cancer, that perhaps could be repurposed for the treatment of this disease. And then we've also tried to develop new animal models specific to granulosa cell tumor that have allowed us to really uncover the molecular basis for the disease, to be smart about how we rationally develop different areas of therapeutics for it. So it's really a different, we've taken kind of a multifaceted approach, and I think that's borne the most fruit so far, and that's led to some clinical trial concepts out of all those areas. So repurposing drugs that are out there for the treatment of breast cancer, or using entirely novel approaches that have come out of our drug screens.
Thank you, and we'll definitely certainly go deeper into this.
Mhm.
But I'm just curious to know why. What it's a good thing that your major interest is in granulosa cell tumors, but what drove you into this and why?
Well, it's just like with a lot of things in research, it's partly just luck and happenstance, and it's partly a really burning interest and a focus on the patients who are affected by it. So
Mhm.
I happened to do some work in this area when I was in my fellowship training many years ago. And that grew into, an interest in the patients and the disease that's really stuck with me this whole time. I think what I'm most interested in scientifically is how closely related granulosa cell tumors are to the development and the maintenance of a normal ovary.
Mm.
So there's really a question of how that process of sort of a normal ovarian function with hormone production and ovulation gets rewired and misregulated to form a cancer, and how that is linked to sort of the fundamental developmental aspects of an ovary. It's all very closely linked to what it means to be a granulosa cell tumor, and I think that is the key to unlocking kind of the real treatment someday.
Mhm. Makes sense. Thank you. So, taking a deeper dive into the granulosa cell tumors, we understand that they are slower growing and not normally very responsive to chemo. So, can you educate us on the typical characteristics of the granulosa cell tumor and what are some of the things that we may not know about this particular tumor type that you would like to share with us?
Absolutely. So I think it helps to think about the ovary as having like a covering, but also like a solid structure in the middle that is what's responsible usually for producing hormones.
Mhm.
So the most common types of ovarian cancer are what's called epithelial and arise from the covering of the ovary. So a granulosa cell tumor is one of the 5% or so that arise from that uh, hormonally productive cells of the ovarian body. So they're quite different in many ways, one of which fundamentally is the connection with hormone production. So frequently, granulosa cell tumors produce large amounts of estrogen and other associated hormones. So this sometimes makes them be diagnosed at a very early stage before they've spread, because sometimes the symptoms associated with all that estrogen lead someone to seek medical care. So in some ways, many granulosa cell tumors come to medical attention or are treated surgically and even cured at a very early stage. However, there's about 10 to 20% of women who are affected by this where, they undergo diagnosis and surgery, and then they, many years in the future, perhaps have a recurrence. And that's the most difficult to treat situation.
Okay,
Now,
go ahead.
chemotherapy, is widely used for many different types of ovarian cancer. For fast growing tumors like high grade serous or other epithelial cancers, chemotherapy can be highly effective, resulting in disease shrinkage sometimes up to 80%.
Mhm.
Now, it doesn't necessarily mean that chemotherapy is never effective for granulosa cell tumors, but the effectiveness is probably about half that. Older studies would say about 40% response rate. So it has a role. We definitely use it, but we're much more careful about when and how we balance that against the side effects of treatment, and sort of embracing kind of the patient as a whole and quality of life factors.
So one of the things that I was thinking when you were talking about breaking it down for us is you talked about side effects that are more pronounced that takes the patient to the physician earlier than later. So does that mean that for this particular kind of ovarian cancer, the the symptoms are a little more different than what we consider the typical symptoms of ovarian cancer? Can you talk to us about that?
Yeah, so I should start by saying granulosa cell tumors typically affect women who are younger than
Mm.
those affected by epithelial cancers, often before or just around the transition to menopause. So 40s and 50s is really the most common. And the production of quite a lot of estrogen can sometimes lead to changes in the pattern of menstrual bleeding. And that can be very, very pronounced, sometimes even quite heavy. Usually that leads someone to seek medical care if they're able to. And that, with their gynecologist, they usually will find an ovarian mass, and oftentimes that's treated surgically and diagnosed as a granulosa cell tumor. That's a very common story for coming to diagnosis.
Okay. Thank you. So you talked about, and this is a great segue into my next question, because you talked about the granulosa cell tumors generally impact the younger population. So I was reading about the adult versus the juvenile GCTs, right? So what are the key differences and similarities between the two types? And also, are the symptoms of this type of ovarian cancer different in children versus the adults? And also even compared to other types of ovarian cancer. So essentially, what is it that we are looking for in terms of our symptoms, and what are the key differences between the juvenile, if any, between the juvenile and the adult GCT?
Yep, that's a great question. Well, so the adult type and the juvenile, it's a little confusing because it actually, even though adult types are more likely to be diagnosed in grown-ups towards the 40s and 50s, and juveniles are oftentimes a disease of young children or teenagers, it actually, you can be diagnosed with the juvenile tumor as an adult and vice versa, that the age of diagnosis does not play into that categorization. It's actually how it looks under the microscope when a pathologist looks at it. So that's a really important part of the diagnosis. And until that's done, usually after surgery, we don't know which subtype we're necessarily dealing with. Sometimes they can even be mixed, combining components of both. So there's some key differences, though. Juveniles do tend to affect, children and teenagers, so that they can produce excess estrogen, and sometimes that can lead to what's called precocious puberty, or sort of the signs and symptoms of puberty, but much earlier, or in a different manner than would be typical. If granulosa cell tumors as a whole are rare, juvenile are extremely rare. So they account for only about 5% of all granulosa cell tumors. So the vast majority of women affected by granulosa cell tumors, they are diagnosed with the adult type of the disease. And just as a result of just that fact, we tend to know a lot more, and there are a lot more, therapeutic options for the adult type.
What you shared is very fascinating, because you just said that it is the two terminologies that we typically use, the adult and the juvenile, is independent of age. So what you're saying is, like you already mentioned, an adult can be diagnosed with juvenile GCT, and then a juvenile could be then diagnosed with an adult GCT. Is that right?
Yes. And while it is more typical that you see them appear in the ages that match their descriptions,
Yes.
there is some overlap. And so it's important to not make assumptions that because of someone's age at diagnosis that it was a particular subtype. You really need to see the pathology report, talk to the pathologist, and know exactly what the diagnosis is.
Dr. Hillman, I mean, is this actually happening in community hospitals now?
I think I want to say yes. I think, that the standards through the WHO and others have improved over the last few decades to such that I do think, even for these rarer cancers, oftentimes the diagnoses are being made correctly. That it's rare, I think, that I see a pure granulosa cell tumor be misdiagnosed. I think where it gets trickier and where you'd really want a specialist pathologist who focuses on gynecologic cancers to be looking at it is when we're dealing with some of the rarer variants of these diseases, or especially when we're dealing with mixed tumors, that is actually relatively common, that you see areas of the tumor that look like the adult type, or that may look like some other kind of closely related cancer. And so figuring out, how to approach it really involves having that expert pathologist and then discussing with them really what they're seeing under the microscope.
Oh, thank you. So we keep hearing from the physician community that, I've asked this question to our experts a few times, What is the research look like for granulosa cell tumors? And very often we are told that research funding is limited because of this rare subtype. So how do you think, and because you're so passionate about this particular subtype, I would love to know how can we shift focus into this type of ovarian cancer so that more resources are invested in this subtype than what is happening now?
It's a great question, Rincy, and I think I've had a couple thought about it a lot. I think on the whole, there's a limited amount of research funding available, whether it's in this country or the world for cancer, for ovarian cancer. So there's just this limited pool. So I think one way to think about it is how do we focus on the common problems that apply to every woman affected by some type of ovarian cancer. So these could include the shared challenges of survivorship, or the side effects and managing the toxicity of some of the treatments we use. So how can we do cross-cutting research that will apply to everyone affected by any type of ovarian cancer? I think that's thinking creatively along those lines is important. I think when it comes to some of the unique challenges of granulosa cell tumors, in my experience, philanthropy and generous gifts from patients and families have really been some of the key seed funding that has led to breakthroughs that then you can take to federal funding like the National Cancer Institute and say, look at what we've already discovered. We would like to expand on this and develop this into, a multi-year research program. So you have to kind of work within the limitations of the rare disease, but we've been very fortunate that there's been a lot of generosity amongst those who are affected by it personally.
Thank you. So in terms of the advances that are in the horizon for this type of ovarian cancer, what are some of the things that you would like to share with our overcomers in terms of the work in progress that you are doing and perhaps others are doing that we are aware of?
Yeah, I think our most exciting discovery that came out of our drug screening efforts in the last 5 years was the discovery that there's a specific hormone called a glucocorticoid that seems to promote the growth of adult type granulosa cell tumors. Now, glucocorticoids are a natural stress hormone and sugar metabolism hormone that the body produces. And so it was really surprising that actually it is able to drive the growth of these granulosa cell tumors. And it's fortunate that we have discovered this because there's actually ways of blocking glucocorticoid signaling. And that may be a very specific way of inhibiting the growth of adult type granulosa cell tumors. And so that's an area that we're actively interested in developing clinical trials that will take it beyond the lab now into like, how can we actually modify this hormone among women affected by this disease and see if that can supplement the effect of chemotherapy or even be used independently.
So what you're saying is this particular hormone is responsible not only for the cancer to form, but also the cancer to grow. Or is it only for the cancer to grow?
We think, well, we know we're pretty sure right now that it promotes the growth of the cancer, and that's through some of the molecular aspects of the adult type granulosa cell tumors actually rewire the effect of this hormone inside the cancer cells to turn it into a growth promoting signal. Now, whether it's something that's important for the formation, that's something we're only kind of scratching the surface on right now. So we don't have the answer to that question, but it's a good one.
Right. And so for the patients to stop the growth of the cancer once they have been diagnosed, what are some of the ways that you are working on to kind of inhibit the growth of this hormone?
Yeah, so there's new and existing drugs that are out there actually for conditions that are characterized by too much glucocorticoid hormone. So these aren't necessarily cancers, but they're endocrine conditions, conditions of hormones. And so there's drugs out there for blocking glucocorticoid activity. And so now we're asking the question of whether some of those could be repurposed for treatment of adult type granulosa cell tumors. And so that's an area that we're developing clinical trial concepts and strategies for.
Okay, so no patient is being treated with that yet. It's just
no.
okay.
But these strategies, have been used with some success in the treatment of more common types of ovarian cancer. So we know that they are safe and perhaps
Hmm.
effective in conjunction with types of chemotherapy, but perhaps for different molecular reasons. And so we're looking at how we can bring those, into the clinic to treat women affected by granulosa cell tumors.
Okay, and what is the timeline for us to see uh, the results to be out or the clinical trial to be read out?
Well, there isn't a trial yet for granulosa cell tumors with this strategy because the discovery
Okay.
is relatively new. But I think
Yeah.
as fast as these things move, I think the science is moving into the clinic quite swiftly with this one. So hopefully within a few years, if things go well, we will have some indication of whether this is going to translate into an effective therapy.
Okay. Thank you. Now, moving on to the recurrent, the type of tumors or where the cancer has spread to advanced stages. What are currently the options and clinical trials that our overcomers should be aware of that you would like to share?
Yeah, so right now I do not know of a granulosa cell specific clinical trial that's open across the country. So there was one last year, and I don't know if it's going to reopen. That was done by one of my colleagues, looking at a combination of endocrine therapies. We're trying though to bring new trial options specifically for this disease. But right now, if you need to look at a clinical trial, I think, what I'm telling the patients that I care for is we look around for really innovative combinations of hormone therapy or immunotherapy. That there was
Hmm.
some very exciting, provocative data from a trial, very small trial last year, suggesting that combinations of immunotherapy may be effective sometimes in this disease. So that data is relatively small and it's early. So I still prefer, if we can, to use immunotherapy as part of a clinical trial where not only can the safety be monitored very closely, but we also ultimately will learn more about what types of immunotherapy might work best for this disease.
Right, makes sense. Thank you. So, from what I understand, and also in talking to our overcomers with this particular subtype, it seems like surgery sometimes is the mainstay for granulosa cell tumors. And so, at what point in the treatment cycle, as surgeons and physicians and care providers, do you decide that no further surgeries are feasible? And when that situation comes, or when that point comes, then what is the management protocol you use to follow these patients?
Yeah, it's a great question. So I think this is the flip side of it being a slow growing disease. So sometimes things like chemotherapy may lose their effectiveness, but being slow growing, it means that if you can do a successful surgery, that often means months, maybe even years before you see the disease come back. And
Yeah.
so after recurrence, I've often utilized many sequential surgeries to try to attain control. And in between, sometimes we might use hormone blocking treatments to take the very small amount of disease that's left after surgery and keep it from growing as long as possible. Now, in my practice, I really strive to have at least a year between surgeries.
Hmm.
I think if you have to do surgery, and these are often very large surgeries with a lot of
Yeah.
recovery time, I feel like the quality of life challenge associated with more frequent surgery can be significant. So I think sometimes we have to think hard about the benefits
Sure.
versus the downside of that. But if it has been more than a year, it really just if we think we can remove the disease we can see on a scan, I almost always will consider that, in sort of a shared decision making model with the patient, like weighing kind of their wishes and how they think about the risks and benefits.
So, on an average, how many surgeries? I mean, I know some patients will have more, some patients will have fewer, but on an average, how many surgeries have you seen in your practice for a patient with advanced GCT?
I think it's very typical to undergo 3 to 4
Okay.
during the total kind of span of a treatment course, and sometimes fewer for a variety of factors. Sometimes, patients choose to not undergo surgery; they'd rather try
Sure.
other
Yeah.
options.
Hmm.
Rarely, though, the disease spreads in a way that can't be managed surgically. This disease tends to remain confined to the abdomen and pelvis in a way that is often treatable with surgery very safely. And so I think that also lends it to, being controlled very well by a surgical approach.
So, yeah, I mean, and just my last part of the question that I was wanting to understand a little better. So, let's say this patient has gone to 3 or 4 rounds of surgeries, and you have determined that no more surgeries for these patients because it's like you said, the quality of life, all of that
Mm-hmm.
into consideration. So, then is it a hormonal treatment that you follow for this particular patient after you have ruled out any further surgeries? What is the
Yeah, very typically, hormonal treatments are sort of a longstanding effectiveness in kind of our understanding of this disease. And so many of those are adopted from the treatment of other hormone responsive diseases like breast cancer, most notably. Things like aromatase inhibitors, which are extremely widely used, for the treatment and prevention of breast cancer. But other hormone blockers like leuprolide acetate, which is an injection that probably has a direct effect on a granulosa cell tumors in terms of slowing their growth. But often I will use the combination of those two. So a pill like the aromatase inhibitor, so just a daily pill, and then a monthly or every 3 month injection of the other hormone blocker, the leuprolide acetate. And that can often be a very effective combination, getting us, often, months or years before we have to do another surgery or
yeah.
switch treatments.
Okay. Thank you. And you briefly mentioned side effects, but I was just going to go do a deeper dive into that because
Yeah.
quality of life and side effects is as important as the treatment itself, right? So, what type of side effects do you commonly see in women diagnosed with GCT on short versus long term, and what should our overcomers be aware of in terms of these side effects, and how does it impact their quality of life?
Yeah, a common theme of a lot of the hormonal treatments we use for treating granulosa cell tumors is how effectively they block estrogen. So,
Mm,
estrogen, in not every case, but oftentimes with this disease, seems to be a key growth signal for the tumor. So, the aromatase inhibitors and the leuprolide acetate, really converge on just reducing the amount of estrogen in the body to
mm,
the maximum extent. So, a lot of the side effects of treatment have to do with the side effects of estrogen deprivation. And so a lot of that could be um, just day-to-day things like hot flashes,
mm,
difficulty with sleep, sexual side effects, mood differences, any number of things that are experienced differently by different people. And so that's a key side effect that can sometimes limit, the ability to stay on a treatment like that. Separately, aromatase inhibitors can sometimes cause joint pain,
mm.
and oftentimes that may be mild and we can sort of manage it together with some pretty simple strategies. But other times I've had to either, stop the aromatase inhibitor entirely or switch to an alternative because that was too big of a quality of life impact.
When you say the joint pain as too big of of a quality of life impact, does it mean that it's literally affecting mobility issues for our
It
overcomers?
can. I mean, that's
Okay.
rare. That's I have
Yeah.
seen, severe situations, but we've in most cases been able to switch to an alternative treatment and had that be much more successful. So it's just a known side effect of aromatase inhibitors that I have encountered.
And this is something that, for our overcomers, I'm saying it's important that they understand that these side effects may happen
Hmm.
due to the treatment and report to the care team sooner than
Absolutely.
later and not think that this is something unrelated to the treatment. So
Absolutely.
that communication with the physician and the provider team constantly is so important so that
It's
you can
very
pick it up
important.
earlier. Yeah. So,
Yes, and
um,
meeting and the other thing, those are kind of some of the quality of life, kind of day-to-day lived experience side effects, but it's also important to realize the sort of long-term effects that estrogen deprivation can have, because even after recurrence, sometimes women with this disease can live for many years. And so monitoring bone density
mm,
is actually very important because, and taking appropriate amounts of calcium and vitamin D can help counteract some of the bone loss that comes over time with these estrogen deprivation treatments.
Typically, as you're talking about the bone density, I mean, this is an issue for any woman going through that
Mm-hmm.
menopausal phase, right? And so it seems like obviously it's more pronounced for the granulosa cell tumor community.
Yes.
So, in terms of though, it just triggered a question in my head is in terms of developing any secondary cancers like the bone cancer or something like that,
Mm-hmm.
is there a risk or that is generally often something that you don't see?
That's generally not something, fortunately,
Okay,
that
that's
we're
good.
in some ways very privileged because these aromatase inhibitors and other similar drugs have such a long track record in the treatment of breast cancer, which unfortunately
Yeah,
is much more common, meaning there's many more women out there with
right.
breast cancer who are taking these drugs. But it also we benefit from that because there's a lot of information about the safety and management of the side effects. So we can then take that information and apply it to those affected by this rare cancer when we use these drugs.
Sure. Thank you. Um, so I think you mentioned that so I was reading that it seems like 1 in 100,000 get diagnosed with, you said 0.5, I think, at the beginning.
It's
So it's even
it
less than
really, yeah,
that.
it sort of
So
depends on which what
yeah,
you're looking at, but yeah.
yeah. So in your practice, how many cases do you typically see in a year? And again, we talked a little bit about the clinical trials, but one of the things that I have talked to our patients and overcomers about, and let's say they're interested in clinical trials, but there's the location
Mm-hmm.
is an impediment because, or the clinical trial has only like 8 seats open and there are
Yes.
100 women that want to be a part of it. So how do we, because it is so rare, the GCT community is always struggling for the next new drug and to get into the next new trial. And again, I mean, in your experience, I know that you don't see as many GCT women throughout the year, but how many do you see, and what recommendations do you give to these women in terms of staying current with which clinical trials are open? How do they improve their chances, for the lack
Yes.
of a better word, to get on to those?
Yeah. Typically, I think last I looked at this, I would see about 20 to 30 new patients affected by this disease every year.
Okay. Okay.
So it doesn't seem like many, but that's quite a lot, I think, for a rare disease like this. And I think that's one of my key advices for overcomers out there is if you are affected by a rare disease, go somewhere and see someone for whom it's not rare,
Yeah,
who sees it all the time because they
exactly.
exist. And I think geographically, there's a few of us now for granulosa cell tumors who are spread throughout the country who really have made this a major emphasis of both our academic research, but also our patient care. And I think, if you can be seen at one of those centers, because that's where, the most clinical trials will be available, the
Right.
most expertise, will be provided during the consultation. And even if your treatment is received closer to home, I always say, I'm part of the team at that point. So after I've been seen for that first consult,
Yeah.
I will often correspond or have phone calls, for sometimes even years in the future, without ever having somebody have to travel again. So I think there's a lot of different care models, but for rare cancers, we're willing to improvise and be part of a team.
So thank you. And my thought is that you said a few of you are spread throughout the country, but my guess is nearly not enough for the number of patients that
Not
are
enough.
looking. Yeah.
Yeah.
So if someone, let's say, is in one part of the country and has some, restrictions with travel, however,
Mm-hmm.
wants to do a second consult with you in instance. So how can the telehealth communication be used for such patients? Because I know there are guidelines and there are, like red tapes around that as well. But
Yes.
so how do we get around that?
Yeah, telemedicine has obviously changed quite a bit as we have gone through and then emerged from the COVID-19
Yes,
pandemic. And it's actually gone through some restrictions more recently in how it can
exactly.
be used across, especially across state lines. So more
Yes.
and more, I'm finding that actually oncologists are reaching out to me directly on behalf of their patient. And then I'm able to have a discussion either on the phone or via email with the oncologist about, what maybe to consider next and whether it's worth coming for an in-person visit, and, provide at least some general advice that way to avoid travel for somebody for whom that's a challenge. And we do that quite often.
That's very important what you just mentioned, that for our overcomers that are seeing other providers, that's something that to keep in mind, that they could potentially reach out to you directly for
Yes.
further guidance and assistance. And then if needed, if the consensus is that it's better for the patient to travel to you wherever you are for an in-person visit, then that determination can then be made by both you and their physician together.
Yes.
So that's great to know. Yeah.
Really emphasizes the teamwork aspect of it, because they have someone that they've known perhaps for many years who's treated them locally, and then I can be part of the team, even though we may be in another state, and provide what kind of input and advice, and we all kind of think through and come up with the best plan together.
Absolutely. Thank you. So in terms of, the biggest challenges that we are yet to overcome in ovarian cancer, on a national and a global scale, what do you think those are in terms of, just not the patient knowledge and empowerment, but just in general, what do you see the biggest challenges in ovarian cancer? Not just granulosa cell tumor, but
absolutely.
in general, what do you see now?
Yeah, I mean, one key challenge is the shift away from federal and public funding of research more towards industry, and especially pharmaceutical industry funding. And while that accelerates, the new drug treatments that we're seeing in the last just few years be made available for our patients, it also means that there's some questions that aren't getting answered, particularly, around things like surgery or certain drugs that maybe no longer have patent protection. There's quite a bit less federal or public resources out there to answer key questions related to those aspects of ovarian cancer treatment. So some of it is, just a decrease in resources overall, and some of it is a shift in the questions that we're able to ask with some of these, larger trial designs that require now really funding from industry or some interest from pharmaceutical companies.
And when you say that when the research is typically funded by the pharmas, not to say, good or bad, but the focus typically lies on the treatment and less on the prevention or the side effects or the quality of life or things like that, right?
Yeah.
So,
well, I want to just be clear. I think, the pharmaceutical industry focus on ovarian cancer has just been an unmitigated good. It's just resulted in so many new treatment options and a new understanding of disease.
100%. Yeah.
I think, though, there are just areas of investigation that are sort of like stones that will never be overturned, if the focus is on, new novel therapeutics. Like, I think as a category, surgical questions are a big one, because, we have so many questions, particularly related to the surgical management of granulosa cell tumors, but even surgical management of more common types of ovarian cancer that have been answered only in fits and starts, and some we may never kind of answer in a definitive way. And so I think but again, I think, if you were talking about novel therapeutics and, bringing new treatment options to the clinic, I think the interest and the resources brought to bear by the pharmaceutical industry have just been an unmitigated good.
200% on that. I agree with you fully. So, so in terms of empowering our overcomers, right, and when they have been diagnosed with ovarian cancer, particularly for granulosa cell type, which is rare in itself. So what questions should our overcomers be asking of their healthcare team? And especially, especially, as I said, if they're told that they have this rare subtype. So at every stage of the disease, currently diagnosed, or, many years into active treatment, what is your guidance to our overcomers?
Yeah, I think it's the same kind of questions that I would tell a family member to be asking no matter what their diagnosis was. I think it's a very reasonable to ask your physician how many of these they've seen in the past year or how many
Mhm.
that they've treated. And I think, anybody should be able to provide a very straightforward answer to that question. And I think it just pays to, with a rare diagnosis, especially, be at least having some contact with, an expert or somebody who focuses on this disease. And even if that is a willingness on behalf of your primary oncologist to reach out and communicate and be part of a team, I
Yeah,
think I'd be looking for that kind of dynamic first and foremost.
makes sense. So for this type of cancer, for this granulosa cell tumors, it seems like there is an ongoing management, and it's a slow-growing tumor, which means that there's always this, audit that keeps happening and the monitoring and etc. But typically in your practice, do you see patients? What is the average remission period that you see patients go into? And have you worked with patients that have never recurred from the GCT?
Well, many times when it's first diagnosed, it's early stage and can be cured. So
Yeah.
sometimes those are curative surgeries, oftentimes
Okay.
not even done by an oncologist. And
Wow. Yeah.
it's the 10 to 20%, though, who eventually recur. Those can be very challenging to then cure because it's often spread to other locations, and is not something that we currently have an ability to get rid of permanently once it's
Okay.
recurred.
Okay.
Now, recurrence with this disease is really surprising in some ways. For other types of ovarian cancer and really most cancers in general, you know, the we ring the bell at 5 years, and that's considered a cure. Now,
Yeah.
granulosa cell tumors, I think, are often recurring for the first time, maybe 5, 10, even 15 years in the future. So it's
Mm.
very unusual in that sense, and it's almost a lifetime worth of kind of low intensity monitoring that needs to be done. Because I think the longest recurrence interval that I've seen is 21 years
Wow.
from initial diagnosis to the first recurrence. So it was dormant somewhere, and then there was some aspect of changes in that woman's life or some environmental factor that caused it to reactivate and grow. So it can be quite a long time between diagnosis and first recurrence. After that, though, we're really pleased if we get a year or two between more between surgeries or between major changes in treatment. And sometimes we can extend that even longer. But I think if we get to, 12, 24 months on a single treatment or between surgeries, I think that's considered, I think, very successful.
Okay. Okay. Thank you. Um, so in caring for our overcomers with granulosa cell tumors, what has been your biggest learning lesson that you would like to share with us?
I am just so moved by how much passion there is in the community. And I think I've seen over the past just 5 years that community become even more connected through Facebook and Overcome and
Yeah.
other
Yeah.
means.
Yes.
And I think that's, more than anything we do on the research side, that almost was a key piece of the puzzle, was to have those affected by this disease and their families be connecting, talking, pushing us forward. And I think that's been really important. So I would encourage anybody with this diagnosis or with a family member with this diagnosis to get connected to others out there through one of these means.
Yeah, community means everything, honestly, especially in situations like this where you feel like you are just one in that, and drop in the
Mm-hmm.
ocean. So let's talk about AI a little bit because everybody else is. So we need
Certainly.
to.
Yes.
So how do you see the role of AI develop in the granulosa cell tumor world and other types of rare ovarian cancers? And um, what because at the pace AI is changing the rest of the world, what do you see its role in reshaping medicine, in helping the physician and the provider team, in becoming more accurate, not only in the diagnosis but also prognosis and other uh,
Yes.
states in the journey? Yeah.
Yeah, I think that's a really big question and an important one. I think
Mm.
there's kind of two ways to look at it. I think there's sort of what can we do with AI right now that's safe and effective? I think most of that is on the research side.
Hmm.
I think AI right now is sort of not being, I wouldn't trust AI with making healthcare decisions, but I do trust it with sort of organizing research papers and helping me brainstorm, what are the most interesting areas that we should be pursuing for the next breakthrough. Because I've used it to take in, dozens of research papers and provide summaries. And
Hmm.
even there's tools out there where you can sort of converse with the AI
Yes.
as a colleague almost. And so, in terms of sort of research concept development, I think it's here. Like it's
Yeah.
definitely supported our research and what I do. I think the bigger question of how it's going to impact patient lives, I hope someday that we'll take all of the healthcare data that's being generated and then be able to use an AI to actually, look at the molecular aspects of the tumor and somebody's life history and choose optimal therapies
Right.
based on that. Now,
Right.
that's an active area of development, but that's we're a little ways away, I think, from kind of the robustness and the safety of seeing that widely used. But that's where I think it's going to head, obviously. Now, there's ways to contribute data out there, especially for rare cancers. There's often registries or, research efforts that are trying to take in and accumulate the data of women who are affected by these diseases. And I think that's a great thing we can do now to contribute, because if we can create databases or, repositories of information about risk factors or environmental causes, then it could be that there's an AI application someday that's sitting on top of those data and provides some true insights.
Yes, and I also think that I think you mentioned about the funding in the surgical space, right? That there's a
Mm-hmm.
lack of funding in the surgical space. So possibly, especially for the granulosa cell tumors, where the patients are subject to multiple surgeries and things of that nature, maybe the AI could be your companion in kind of more accurately kind of diagnose, not diagnosing, but just kind of suggesting whether this patient is good for another surgery or not,
Yep.
or things like that. So
Absolutely. Yeah. As almost a companion or co-pilot to the surgeon during the
co-pilot,
planning
exactly.
process. Yes. Yes.
Exactly,
I think that's
exactly.
the model we'll see in healthcare is as an assistant or co-pilot for some of
I
the
hope
planning
that,
decisions.
yeah, I hope that that is the model we see, because we do not want to go to doctors for robots, at least not yet.
No, no. You don't want AI diagnosing you just yet. So yeah.
Right, not just yet. So we have talked about a lot of things, Dr. Hillman. What have I missed asking you that you would like to share with our overcomers?
No, I think we'll all benefit from like you do, really seeing ovarian cancer in all of its, multiple differences, but really as one disease, that can profoundly affect patients and their families. And I think, the focus of Overcome has been really impressive to look at the cross-cutting ways that we can help those patients and families, regardless of the specific diagnosis. So I really appreciate you taking so much time to talk today and understand, this particular rare disease.
Of course, thank you. And in your message to women diagnosed with granulosa cell tumor, especially for the younger women with granulosa cell tumor, the younger women face so many other challenges in life, which is non-cancer, right? It could be relationships, it could
Mm-hmm.
be family, it could be like a new job that they have started, multiple other things, right? Education. So how, in your opinion, what guidance would you give to the younger women who have been diagnosed with granulosa cell tumors on how they should advocate and overcome the challenges they generally face in receiving timely treatment? And I bring this up because we talk up to so many of our younger overcomers who repeatedly tell us that they got blown off by the care team, saying that you're too young to have cancer, and they kept going to the provider saying, no, I don't feel right, there's something going on.
Mm-hmm.
So what is your message to our younger community of women?
Yeah, well, it really emphasizes importance of advocating for yourself, but
Yeah.
also, finding the right doctor if you don't feel like there's a good fit. And
Right.
also, there's someone out there probably in your same situation. And so one of the good aspects of social media is the
Mhm.
increased ability to find those communities and other individuals who may have had a similar shared experience. And I think that can add a lot in a sense that you're not alone, even though the diagnosis is rare. There's others out there who can help you understand it.
Wonderful. Thank you. And this is a question I ask all my episode guests what message of overcoming would you like to share with all our overcomers listening today?
Well, I think, no matter if you're personally affected or your family member, I think being involved in such an organization like Overcome with such a track record of advocacy and support, I think that's a key first step beyond, your own clinical care. And I just am so supportive of that and encourage everybody to participate in that or other kind of advocacy efforts.
Thank you so much, Dr. Hillman. This was a fantastic conversation in the sense that we have really never, before you, we have never really emphasized or focused on the granulosa cell tumors, and it's just so wonderful to hear all of the great insights and the work and the novel therapeutics that you are currently involved in and working, to bring a better tomorrow for all our patients in the granulosa cell community. So we thank you for all the work that you do for this community and for in general for what you do for the patients. So thank you so much for your time, and overcomers, hope this episode was beneficial for you, especially to my GCT community. I would request, please share this video far and wide with anyone who may benefit from all the pearls of wisdom and all the great insights Dr. Hillman shared with us today. And we will be back with the next episode of Connect Ovar Coffee very soon. Until then, you keep inspiring and keep overcoming. Thank you and bye.